Let me recap what we have learned so far. Dr. G talked about Parkinson disease 101, gave you the introduction. I and Dr. Beversdorf talked about the non-motor symptoms of Parkinson disease. But some of you might be aware of surgical options in Parkinson disease. Some of you might be aware of a new drug delivery system. And you might be wondering which people need those interventions. That intervention, that surgical intervention, is deep brain stimulation therapy, and that drug delivery system, the new drug delivery system, is Duopa system. And to talk about that, today we have Dr. Siddiqui with us. Dr. Siddiqui recently joined the immune neurology team and will be leading the movement disorders clinic. He is dual subspecialized in movement disorders. He did 2 fellowships. He finished his residency in University Hospitals Cleveland Medical Center, did 2 clinical fellowships in movement disorders at Case Medical Center and Cleveland Clinic. Some of you will be seeing him. He is our colleague, and as I said, he will be leading the movement disorders clinic. And without any further delay, I welcome Dr. Siddiqui.
All right. So, these are the topic: deep brain stimulation and LCIG, which is short for levodopa carbidopa intestinal gel, better known as Duopa. These are the interventional therapies for patients with advanced Parkinson's disease, people who have Parkinson's disease and their symptoms. It is becoming difficult to control their symptoms, or they start having side effects from the medications that they're using. So that's when we consider patients with, for these interventional and advanced therapies. And so we'll start with deep brain stimulation, or DBS. So what is it? This is the most frequently performed interventional therapy or neurosurgical procedure for Parkinson's disease. It was FDA approved for Parkinson's disease in 1997. And it's, the indications for DBS are growing. We also offer it for patients with essential tremor. Sometimes the tremor may superficially resemble patients who have Parkinson's disease, but it's, it's different. And then dystonia, and some people who have drug side effects, they can also, they can be candidates for deep brain stimulation. And it's still, the list is increasing every day. So the question here is, I try to design these slides as the simple questions that come to everybody's mind. Okay, does DBS really help? Well, there have been several studies on that, and so it does increase the on time. I'm sure as we go through the journey of Parkinson's disease, and we meet same physicians or similar physicians so many times in the clinic, we are educated, and we are being told, okay, this is what on time means, this is what off time means, dyskinesias and other terminologies that we use. So on time means that when you have taken the medication and that you are feeling the benefit of the medication and it's helping the symptoms, that's the on time. Off time is when the medication has worn off and you are symptomatic again, you start having the tremor, the stiffness, the slowness. So that's the off time. So so it increases the on time without dyskinesias. I'm sure a lot of you guys already know what dyskinesias are. These are the fidgety movements that come when you take Cinemet or carbidopa levodopa and you're moving more than normal. So if you have DBS, it increases the amount of on time and without increasing dyskinesias. It also improves quality of life. There have been several surveys about this, and it improves the off time by 4 to 5 hours. That means it either reduces the duration of off time, or when you're off, then you're less symptomatic than if you were not taking the medication. And then it also reduces the amount of medication, and of course the medication induced dyskinesias, because once you have deep brain stimulation and it's working 24/7, it takes up some of the work of medications, and then you are allowed to reduce the doses of some of the medications. So does DBS prolong life? Well, not directly, but there was a study, and I wanted to throw that in there, that compared 106 patients who underwent DBS in a particular site, the STN DBS, and to 41 who opted not to go for the procedure, and they went just for the best medical management. And then, so it actually reduced mortality. If you can you see the numbers, 17% versus 41.5%. And it also reduced the nursing home admissions from 5.7 versus 36.6%. So this was probably from better symptom control, increased mobility with patients who have had DBS, and improving the difficulty in their swallowing, because once you start having difficulty swallowing, you start choking, you end up having aspiration pneumonia, and that can end up being in the hospital for that, and then that's a further step down. So that was like very promising, and I thought that was encouraging. So what are the kind of patients that will benefit from deep brain stimulation? First of all, of course, so I won't be talking about the other indications for Parkinson's disease. So patients who have established Parkinson's disease. When anybody comes to the clinic and they have symptoms of Parkinsonism simply means that you have the 4 cardinal features, or 3 of the 4 cardinal features, which is the tremor at rest, rigidity or stiffness that you feel, akinesia or bradykinesia or slowness of movement, that you can't walk fast enough, and postural instability. Then when you walk, you have difficulty balance. So you have to have 3 of those 4 to be told that you have Parkinsonism, and the commonest cause of Parkinsonism is Parkinson's disease. And once you have those symptoms and we think you have Parkinson's disease, we give you a trial of medication, and then if that medication helps you significantly, then we know, okay, this is medication responsive condition, and then we would ideally like to wait for a few years and see how the disease progresses and how you continue to respond to medication before deciding that, okay, there's no doubt about it, this is Parkinson's disease. And then those patients we're more comfortable with, suggesting that, okay, yes, you can have, you're a good candidate for DBS. So patients with Parkinson's disease. Now, patients who have Parkinson's disease and have tremor, or they're called tremor predominant Parkinson's disease. Sometimes the tremor does not respond to medications. And so it would help in the slowness, the stiffness, and sometimes the walking, but does not, help the tremor as much. In those patients, they can still go ahead and have deep brain stimulation surgery, and that has shown to improve the tremor as well, in addition to everything else. So it helps all the 3 things of tremor, stiffness, and slowness that you experience with Parkinson's disease. Patients with Parkinson's disease, as years go by, when you take medications, of course, the Cinemet, you take 3 times a day, 4 times a day. People take more frequently than that. So medication goes into your system. It goes, it elevates in the system. It starts working. Then it goes down, and you start having symptoms again. And then you take the next dose, and then it goes up again. So there's a fluctuation in the amount of medication in your system, and that results in improvement in your symptoms and then deterioration. So that leads to motor fluctuation. And with time, people develop, that becomes problematic. People sometimes fall from just sudden offs, and the medication is just suddenly wearing off. So if you have DBS, that has shown to improve that, and people don't have the sudden offs, and it's more predictable. It's more smooth, so it doesn't go up and down like this. It's working 24/7, and then with the medication help, it's even better. And of course, dyskinesias, like I spoke about earlier, if you continue taking Cinemet and other dopaminergic medications to help with your symptoms of Parkinson's disease, with time you start having dyskinesias, which are excessive unwanted movements. So going from not moving as much to moving too much when the medication is working. sometimes these dyskinesias can just be controlled by reducing the dose of the medication, but then you have to strike a balance between becoming more stiff and slow and having more tremors, and then less of the dyskinesia. So if somebody has deep brain stimulation in those patients who have dyskinesias, it has been proved that the dyskinesias improve and the symptoms continue to be improved as well. So what does DBS entail? Of course, first of all, you make the diagnosis like I played out initially, that you have those symptoms and we think the diagnosis, we're comfortable with the diagnosis, and then we say, okay, the cognition, you're alert, you don't have a lot of memory problems to start with, and then we do something called a levodopa testing or on-off testing, which simply means you've been on this medication, carbidopa, levodopa, or other medications like Sinemet, and they've been helping you. So what we do is we need to find out how much have they been helping. So we ask you to, okay, you stop your medication a day prior to coming in for a test, and then we examine you in the clinic off the medications. So you're off at that time. That means we see the symptoms at their worst. You're very stiff, you're very slow, you may be shaking as well, having difficulty walking because of all these symptoms. And then we examine you in detail and do a rating scale, something called a UPDRS. And that's like a standardized test. And we ask you to do these finger movements and hand movements and rate them. And rate them so we find out what your score is. And then we give you your medications and a little bit more to give you the best chance of seeing how much these symptoms respond to medication. And then we examine you again after whatever time some people say the medication kicks in like half an hour, some people say it's like 45 minutes, in some people it's about an hour or even more. So we give you that time and then we examine you on your on state. And that's when we need to compare the scores. So if the scores are 30% better from your baseline or your off scores, or even better than that, then we say, okay, then DBS is something that we can do for you. And the only exception to this is people whose scores are not as good and they continue to have tremors. Like I mentioned, tremors, even if they don't respond to Sinemet, they still respond to DBS. So that's how we go about doing it. And then so once everything is decided, okay, you respond to medication more than 30%, you're still a candidate, and then we ask you to see other members of our team, which are the neurosurgeons, the psychologists, the psychiatrists, the physical therapy, occupational therapy people, and then we convene and then we say yay or nay. This person does not have significant cognitive difficulties. He's still ambulant, or he or she is still ambulant. Their symptoms respond, beautifully to medications, and they're physically healthy otherwise. So you want to, you want to give the green signal and go ahead with that. And so that we go for surgery, and then after surgery we have programming of the DBS, and then we follow up in the clinic. And this is what is depicted in this flowchart. I don't know if you can see it that well, but that's essentially what I just laid out to you. So who with Parkinsonism should not get DBS? Parkinsonism from other causes that is not Parkinson's disease should not get DBS, like dementia with Lewy bodies, like PSP, like CBGD. This is another medical, so mouthful. But these are other brothers and sisters or cousins of Parkinson's disease that you don't want to give, don't want to treat with Sinemet because you want DBS because Sinemet doesn't work for these or works marginally, and they don't respond, and they're pretty aggressive conditions. So you want to, first thing that you want to do if you have Parkinsonism is to find out if you have Parkinson's disease or you have some of these other entities, and you're lucky if you have Parkinson's disease. So in DBS, so people may ask, okay, should we do one-sided surgery or both-sided surgery? So that's debatable, and generally we do both sides if the patient is symptomatic, especially on both sides, or they're healthy and they can have surgery, because we expect, because it's a gradually progressive neurodegenerative condition. If somebody has it on the right side first or the left side, then you can expect that over the years it will start involving the other side as well. And then sometimes we do it in one go, like the same setting we do both placement, or we sometimes do it stage, that we do one side and then after years or a year or two or later the other side. And then of course patient preference, or whatever the patient prefers, we recommend, and the patient's health, of course. So what are the complications of deep brain stimulation? Infections in 1.2 to 15%, depending on which facility you choose. And sometimes if there's an infection bad enough, that can involve the leads or the wire that goes down to your chest, that may require removal of the hardware, but that's not very common. Of course, it is brain surgery. If you insert leads in there, you can expect bleeding. 5% of patients actually have bleeding, and in 2.1% they end up in having permanent deficits, like a stroke, and then 1.1% end up dying from those bleeding. So it's not something very trivial. So you want to make sure that you're healthy, you do it as early as possible. Some people develop seizures from it, 2.4%, confusion, but these are temporary. And then of course, once you place the leads in there and you give the electric current, it causes stimulation of the amount of tissue that that helps the symptoms. And then if the current goes beyond that area, you can have side effects, which are called stimulation-related side effects, but they are all reversible, because that's the beauty about deep brain stimulation, that you can change the current to improve the symptoms. So as the disease progresses and you start having more and more symptoms, you can just increase the current and the settings, and that will actually help with controlling symptoms as the disease progresses. So it grows with you, so to speak. So it's very, very effective. So that was about the deep brain stimulation. I'm going to go ahead and start talking about the LCIG or Duopa. So we all know that Cinemet that we do use, or carbidopa, levodopa, is usually like a short-acting medication, and you have to take it many times a day to have the benefit. And then when you take it many times a day, you end up increasing and then reducing and then increasing. So the fluctuations in your body and that causes the side effects as well. So that's what they thought about when they invented Duopa, which is actually a suspension of carbidopa and levodopa, which is the same thing as Cinemet, and then they mixed it with methyl cellulose, so it became a gel, and they deliver it via a pump. The peg tube, the feeding tube, sometimes you will get. So it's similar to that, and then a pump is attached to that feeding tube, and then it gives you the gel continuously. So who would benefit from LCIG or Duopa? Of course, patients who have Parkinson's disease and they respond to medication, and then those patients who require frequent doses, and that results in marked fluctuations. Just the things that I just mentioned initially. Does it work? Well, it does. Several trials across the Atlantic, showed that it does. There's significant reduction in off time, similar to DBS. There's more on time by 4 hours or more without dyskinesias, and then significant reduction in UPDRS scores. Sometimes helps in freezing of gait, even if it does not respond to other medications. And improvement in non-motor symptoms. Sometimes people tend to sleep better with this medication, and of course when you have a streamlined dose of the medication, it helps with cognition and hallucinations as well, and then improve quality of life. So how do you approach a patient? What are the steps? So make sure you have Parkinson's disease. You can have an on-off testing. Some people actually do a trial of they put a nasogastric tube instead of doing the PEG tube, nasogastric tube, and giving the levodopa gel through that tube and see how it works before proceeding with an invasive procedure like a PEG tube. And then once that they have established that it does work, you can go ahead and do that. And then PEG tube placement, and then you attach the pump, and then it start working. Complications, procedure-related complications, these are commonest, and then early as well, up to 90%. Wound infection, pain, redness at the site. Device-related complications, accidental removal because it's like a pump is attached to it, and occlusion of the tube, and then medication-related. That you may have to reduce or increase the dose of Sinemet. Some people who have B12 deficiency or folate deficiency, they can sometimes develop neuropathy. So we can check your vitamin levels before this, and then we can try to avoid that. And then abdominal pain from the procedure, or falls and insomnia can sometimes happen. So conclusion, more options, more power. Advanced therapies, these two therapies have been there for several years, and they've proven to be of benefit. And and there's another procedure that is in the pipeline. It's called apomorphine pump. It is already being used for years in Europe, but now it's being just so that it's approved by FDA here. They're also working on it here in a clinical trial. And then when that is done, that's also a very useful procedure that we can consider starting here. So you have the DBS, and you have Duopa, and then hopefully we'll have apomorphine pump in the future. And then so just to for a variety of disease stages, not just the disease but the health status, the age, so we can consider which procedure would best fit that person, and then what your hopes and aspirations are. And thank you for your attention, and these are my references, and I can answer any questions. So, does DBS help with balance and or speech? And what if the life cycle of DBS? Okay, so that's a good question. So DBS, does it help with balance? So if people who have balance difficulties that actually respond to Sinemet, some people have what is called freezing of gait. That means when you're walking, you approach a line, and then you suddenly freeze, or you're walking through a narrow corridor, or you're entering an elevator, and you suddenly freeze for no physical reason, but just you can't move. And then, so that's called freezing of gait. In some people with Parkinson's disease, that actually responds to Sinemet or carbidopa-levodopa. And in those patients, especially when we do the on-off testing and we ask them to walk around doing the UPDR scores, and if it responds, then yes, it would respond to DBS as well. So all the symptoms that respond to Sinemet or carbidopa-levodopa, they respond to DBS. The only exception being of the tremor, which may not respond to Sinemet, but still responds to DBS. So the same thing goes with speech. The speech doesn't usually improve with DBS. It does not, because the dysarthria, dysphonia, you can there are a lot of therapies, speech therapies that we recommend people go to, and then that sometimes helps, but not usually DBS. And what's the life cycle of DBS? Well, DBS it has I have not seen any. So the leads, if they don't fracture, if they don't they don't get infected, then that's indefinite. But that's sometimes if you get the stimulator, and then the battery can run out. Okay, and that depends on of course how much intensity, what current you're giving, and in those cases the battery needs to be replaced maybe 3 years, 4 years, and then that can be monitored every time you come to the clinic. We can monitor that. So that's that. One thing I want to mention here is that DBS is completely reversible. So it's not like a one-time deal. Okay, so it's not like you know what, it's a no, I can't go back if I do DBS. So if people think, okay, you know what, I'm having too many side effects, I'm having this or that side effect, and I don't really want this, so it can be taken out, and it does not destroy brain tissue. Although the leads go in, but it does not destroy brain tissue. So people, so you can have it removed. It's a completely reversible procedure. Okay, is having a DBS battery on both sides common, and is it beneficial? So there are people who have, because Parkinson's disease is like 24/7. You have the condition 24/7. It does not. Sometimes people have difficulty turning in bed. Sometimes they have to go to the bathroom at night, and then so we prefer that the DBS remain on 24/7. And then because if you want to get up at night, you want to be able to make it easy for yourself to do that. So yes, we do. I mean, it is what it is. If you need it, you need it. If it's helping your symptoms, if it's making you walk faster and have better balance and less stiff, and then being able to do what you want to do every day, then yes, it is beneficial to keep it on 24/7. And is it possible for a person with Parkinson's disease to have both DBS and Duopa pump? I guess it's not impossible, but they're not mutually exclusive. But the population of patients that we do, the type of patients that we do Duopa is a little different from patients who have Parkinson's disease, for those who go for DBS. Like Duopa is a less invasive procedure as compared to DBS, and and it's more easily reversible. I don't think both. I haven't seen any patient with both the things done at the same time, because they wouldn't need it. If DBS is working, I don't think they will need Duopa pump. Okay, and one of the reasons that we do DBS is because you want to avoid some of the side effects of higher dose medication, including Cinemet. So it wouldn't make sense to be giving you an invasive procedure to counteract the side effects of a medication and continue to give the medication at the same time. So I'm not sure if that's going to be possible. So how is the patient referral for testing to determine if DBS is an option? It seems that this patient has a need for DBS, but her neurologist doesn't seem to want to consider it. What do we do? So so the best bet to have to be evaluated for DBS is to go to a movement disorder specialist in a center that offers DBS. Okay, in some places, general neurologists may have heard of DBS, but they may not have seen patients with DBS. So they may not be entirely comfortable. They may not know everything about it. So if you really want to consider it, if you think you can be a candidate, you can just ask them, can you please refer me to a movement disorder specialist? Okay, and then I think that would be the best option for a fair evaluation that you really benefit from DBS or not. Could we see how many people today have had DBS surgery? Raise of hands. Good. Okay. And for DBS and LCIG, what type of anesthesia is used? General. It's a good question. For DBS, it is because it's multiple stages. The first stage, of course, when you implant the leads, what we do is we come in before, and we do your MRI, and the neurosurgeon and the neurologist we decide where the leads go, what tangent and what angles. Excuse me. And then, so you come in the morning, they shave the head, and then they put a halo around the head, and then that helps. So that's sort of painful. So we numb that area up, and then once that's in, we put you to sleep. And once you're, general anesthesia, of course, and that's general anesthesia. So once that happens, then the neurosurgeon, drills holes, like dime-sized holes on both sides, and then puts in electrodes, and then I used to do this back Case Western, is intraoperative microelectrode recording. So we place the leads in, and then we listen to the brain tissue where we have to, stop and stimulate. And when we stimulate, that's when we wake the patients up transiently. So we wake you up, and then we ask you to do these things again, the same thing that we do in the clinic, hand and this thing. We ask you to write, and sometimes and feel how stiff you are, and that stimulation is actually improving those symptoms while you're awake. In some people don't do this, the intraoperative recording, and they just place the leads, and then so it can be done both ways. But I've been used to doing that. So we wake you transiently up, examine you, make sure that stimulation is actually working, and all your symptoms are actually going away with minimal or no side effects, and then we put you back to sleep, and then we finish the procedure, and then you wake up later. So that's the DBS. And in Duopa, of course, this is it's actually much like a PEG tube or a feeding tube placement. It doesn't need general anesthesia in general. It's just local. Sometimes we can give you some medication to make you a little drowsy and sleepy, and then that can. I don't think it needs a general anesthesia. What is I don't know the cost of DBS. Okay, cost of DBS. So the cost of DBS is, I am not entirely sure what the cost of DBS is. Something I can find out, I guess. So how long is it effective? So the DBS is effective, like I said, as long as you have the disease and the leads don't crack, and you don't fracture the leads, or so if nothing other thing happens to the instruments in there, it can last as long as you do, essentially. Is there a type of DBS that offers a full body MRI? So the DBS does not change. DBS is the same, but then there are certain centers that have protocols so in general we tell people, okay, once you have DBS, you do not have an MRI. That's true in general, because most of the centers don't have the facility, because you need a magnet of less strength, and some certain protocol to do MRI, and not everybody can do it. So in general we tell them no MRIs after DBS. So is DBS amenable to all who qualify? This is no equipment. I can't read this, I'm sorry. Okay, the time of on or off medication for testing on, time or off. So I think what they're trying to ask here is medications on off is too short, the time for the testing. So like I said, the testing for UPDRS, when you do for the on-off testing to determine if the DBS will really help you, is we ask the patient, okay, how long does it take for you to, the medication is completely out of your system. So that's why we ask them to stop taking it a day prior to coming in. And then we ask them how long does it take to kick in when you notice, the medication is starting to help. And that's when we start examining. So we don't start examining the patient before that time. Otherwise, you wouldn't have the best, best trial, so to speak, of the medication. I think those are all the questions I have. Any other questions anybody has? Okay. Well, thank you so much.